from the Alzheimer's Society of Toronto. I wanted to thank you and welcome you to our session today on advances in dementia research. Just so you know, we are recording the session. So if you are concerned about your face showing up, you can actually stop your video. The recording will be posted on the Alzheimer's Society of Toronto YouTube page, as well as with Dr. Tartaglia's organization as well. So you will be able to revisit this, and we will also be able to share with you slides after the session. Okay. Some other things to keep in mind is we have muted everyone just so that we can hear clearly throughout the presentation, and you're most welcome to use the chat feature throughout the presentation to ask any questions that you may have. I have two other co-hosts with me. I have Elena and Maria, and we will be monitoring the chats just so that we can bring up the questions. And there will also be a time at the end of the session to ask any of the questions that you may have of Dr. Tartaglia. So without further ado, I would like to invite Elena to introduce our speaker today.
Okay. Hi, everybody. Good morning. So Dr. Tartaglia is a cognitive behavioral neurologist at the UHN Memory Clinic, where she sees patients with neurodegenerative diseases and persistent symptoms of concussion. She is a scientist at the TAN Center for Research in Neurodegenerative Diseases, where she uses a multi-modal approach for biomarker discovery to facilitate diagnosis of neurodegenerative diseases. She is a member of the board of the Alzheimer's Society of Toronto and scientific advisor to the Women's Brain Project, PSP Canada, and Brain Injury Canada.
Thank you. And thank you all for coming. So I will get started. So we're going to talk today about advances in research, but I think it's really important to remember that advances in research really come about because our thinking of what dementia is has really taken a stride. We've made a lot of progress in dementia, into diagnostics of dementia, and I think that's really important and often overlooked. So we'll talk a little bit about what dementia is and how we diagnose the different types and why it's important to do that, and then get into the latest research. So I think you probably all know that we all need to be thinking about dementia, whether for ourselves, people we know, the society at large, because we have done a really good job at allowing people to reach ripe old ages. And so the fastest growing part of our society are people who are in the older ages of 85 and older. And that means that they are at the highest risk of dementia because age is the biggest risk factor. As well, I think it's important for us to realize how costly dementia is because it affects a large number of people. Just in Canada alone, these are figures from 2011, that capturing all types of causes of dementia, but there were 740,000 and very, very expensive. And with the growing numbers, it's going to become even more expensive. And that's an economic cost, but also a huge societal cost, right? Because we all pay, whether psychologically, emotionally, or financially, for anything that affects a large number of our society, as we now know. And so what is dementia? I think it's important to realize that dementia is a syndrome that includes a number of criteria, and basically it relates to cognitive and behavioral symptoms that interfere with your work or your usual activities. It has to represent a decline from previous level of functioning, not due to delirium or psychiatric disorder, and it has to be a detectable change in your cognition so that we can test, we can ask informants and say, yes, something has changed. And it could be a problem with memory, it could be a problem with thinking, reasoning, concentration, it could be a problem with navigating, visual processing, it could be a problem with language, or it could be a change in personality. But dementia does not equal Alzheimer's disease, and this has been a big problem in our society and a problem for everybody. because a lot of people get misdiagnosed. A lot of people assume that when they're given a diagnosis of dementia, they have Alzheimer's disease. And that has huge ramifications, because you can imagine when you're trying to get into a study on Alzheimer's disease, if you've been misdiagnosed, that doesn't really help the research get ahead. As well, if you think of people worried about family histories, you know, I have patients who come to me and they tell me, I have a lot of family members with Alzheimer's disease. But when you start to talk to them, you realize that actually none of them had confirmed Alzheimer's disease, and most of them probably had something else. So I think it's really important for us to realize that dementia does not equal Alzheimer's disease. Dementia is really an umbrella term, and although it includes Alzheimer's, it includes vascular disease, it includes Parkinson's disease dementia, frontotemporal dementia, aphasias, corticobasal syndrome, Lewy body, chronic traumatic encephalopathy, Huntington's. It also includes normal pressure hydrocephalus. It also includes all these types of illnesses that, you know, we really don't even think of when we're as a neurodegenerative, but they also cause dementia. So multiple sclerosis can cause dementia, brain trauma, infection, autoimmune disorders. And that's because, as I described, dementia is really just a term that tells you you aren't able to do what you used to do before. And it's due to your brain. So I think it's really important to think about that. And so when we see people, we really spend a lot of time trying to get a history, because that does actually help us figure out what the cause of a person's change is. So we ask about memory, we ask about navigating, recognizing of faces. We ask about language. Does the person have trouble finding words? Do they have trouble understanding words? You know, we ask about planning and multitasking and problem solving, things that, you know, most of us do every day and have no issues with, and dementia can change. We ask about concentration. And then obviously we ask about personality and behavior. I think anybody who has somebody that they know with dementia realize how much the personalities can change and the social interactions can change. When people come to our clinics, we often do a certain amount of assessments where we actually try different domains that are involved in cognitive function. So you probably know the MMSE or the MoCA. These are the most common tests, but there's many different types of tests. And I know sometimes people find them quite annoying, but for us, it's really a way to tap into the different parts of your brain to figure out, you know, where the problem is. Because when we think of the brain, we think along these lines. Different parts of the brain subserve different functions. So if we see that you're having a lot of trouble with your language production, but your language understanding is good, well, we think that's like left frontal area problem. If we think, oh, you have a lot of problem with, you know, processing visual information and arithmetic, and, you know, you're not able to do things like you used to do, then we think, oh, that must be more posterior problem. So it really helps us when somebody gives us a history to do a little bit of testing and to try to figure out where in the brain is this happening. And the reason that that's important is because different diseases affect different parts of the brain. So we use MRI, and these are 6 different MRIs to help us make a diagnosis, okay? And I think you can appreciate that all these brains look very different. And you don't have to worry about the different diagnoses. Those are just to tell you that these are 6 different diseases. And, you know, you wouldn't want somebody to give you the wrong one, because you can see that those brains do not look the same. And so when we look at a person that we think has Alzheimer's disease and we look at their brain, we look for certain patterns. And when we think of vascular disease, we think of a different type of pattern. And if we think of semantic variant, we look at specific parts of the brain. So this is just to tell you that when we are doing an assessment or figuring out what a person has, because that in the end will dictate the treatment, we use all the means we have available. Now, unfortunately, MRI is kind of a late stage, so we are moving towards getting better diagnostic measures. So here is, I think, a really important slide, because when patients have donated their brains for research, we see how often Alzheimer's disease comes up in a dementia cohort and how many times it does not. So this is kind of the spectrum of disease that we see repeatedly when people generously donate their brains. And 40% of those brains have Alzheimer's disease, and 60% have something else. And so I think it's really important to keep that in mind. And this is why it's really important to understand that dementia does not equal Alzheimer's disease. When we think of this, was from a large study from the US, I think. And it was at that time, in their brain banks, they had found 5.3 million Alzheimer's disease, 1.3 Lewy body, over 100K of frontotemporal, and 700,000. So you can see Alzheimer's disease played a really big role in this group, but there were a lot of other entities that needed to be considered. So we now are really lucky in Alzheimer's disease because we actually have ways to make the diagnosis. So we can look at the cerebrospinal fluid from a lumbar puncture, and there are PET scans, which are a nuclear kind of scan, and we can look for something that lights up in the brain, and it tells us that there's some amyloid there. And the important thing is that now, definitively, when people are still alive, we can tell them they have Alzheimer's disease. And in fact, this is not that long ago. It's not that long ago that in practice, this was not being done. And so in 2013, there were a number of really large trials of Alzheimer's disease where 30% of the patients in the trial were found not to have it. So this would be the equivalent of 30% of patients in a colon cancer trial having lung cancer and being given a drug that only works in colon cancer. You would find that completely unacceptable. People would probably get sued, but in our case, the only thing that happened is a lot of these trials failed. So as of 2013, you now need to prove you have Alzheimer's disease in the brain to be able to get into a clinical trial for Alzheimer's disease. Now you're probably thinking, but clinically, I've seen my doctor and they told me I have Alzheimer's. Nobody did any tests for me. And that's true, because unfortunately, these tests are not being used clinically. So we used to be able to check for the one for lumbar puncture. We used to be able to check, and it was covered by OHIP. But in March 2019, actually, they stopped covering that test. So as of today, we don't have any means to clinically do it. So we can only do it in research or when people pay for it, which is unfortunate. But we are hoping that in the future, especially in the very near future, this will change, because we need to be able to tell people that yes or no, they have this disease or not. So this is just to tell you how often we get it wrong. It's actually not that uncommon. This was in a very large study. 78% of patients were given the right diagnosis. 11% were diagnosed with Alzheimer's but didn't have it, and 11% had it and didn't get diagnosed. That's a pretty significant number of people. And so if you think repeatedly, and this was done in specialty clinics, not in the primary care. So we probably have a lot of people who are going around with misdiagnosis. And now I think it's important for us to understand this concept, because I think this is where we can think of disease and treatment of this disease. So Alzheimer's disease, Parkinson's disease, all the causes of dementia actually are associated with a spreading of disease throughout the brain, okay? And the spreading of disease throughout the brain occurs over time. And that means that we do have the hope of being able to stop the disease before it spreads throughout the brain. Each of the diseases have specific patterns, so we know what to look for. And so we do know that there is time between when the disease starts and when we get to an end stage of the disease. And in some cases, like in Alzheimer's, that could be 30, 40, 50 years. The same for Parkinson's. Some of the other causes are a little bit less. But in these diseases, we actually have a long time to be able to intervene. So it really means that we're working very hard to pick up on the disease earlier and to intervene earlier. And so the concept of what it means to have a disease has completely changed in the last few years. Because of this idea of spread, we now know that you start to accumulate disease in the brain 20 to 30 years before you show any signs of disease. And then you have a short period of time where you have mild cognitive impairment, and that's another time where we could intervene. And then you start in your, the phase of the disease called dementia. And so we are working very hard to be able to pick up on the asymptomatic people, as well as the mildly symptomatic people and early dementia, so that you can stop this disease at a time where, people can still have a good quality of life. And we have different markers, and those lines there are just to tell you about that. We have markers that show up way before there's even changes in the brain. So I showed you MRIs. Those were those pictures, with all the different names of them. But those pictures show a lot of brain that's missing. Now, I think we can all appreciate that we do not want to be picking up a disease when there's so much brain missing. We want to be able to pick up the disease when the brain is intact, because to date, we cannot give people back brain. But we are hopeful that we will be able to stop the disease early enough so that a lot of the brain remains preserved, okay? And so I think here you can see all these changes that occur, but this line and this line are where there's actually brain shrinkage happening, okay? And when brain shrinkage happens, it's really a time where you will show the signs of dementia. So mild cognitive impairment is the stage before dementia. And like I said, it's a time where people will come to us that they have concern about their cognitive function, but they are still completely functional. They are not demented. But we know that many of these people have a disease in the brain that is going to lead them to have dementia. And if you look at the numbers, a good chunk of these people will have Alzheimer's disease, but some of them will have something else. And a lot of the time we think about memory and we think about cognitive function, where that includes things like thinking and language. But we have to remember that the brain also subserves all of your behavior. And we recognize that there are some people who will present with a mild behavioral impairment and not a cognitive impairment. And it's very important to pick up on that, because this could be the first sign that the person is headed towards dementia. There's a new concept that has come into, popular culture in the last few years, and that's subjective cognitive impairment. So these are people who, they feel like things are not what they used to be. They are not able to do things the way they used to do them, but they're still highly functioning and they're doing everything they want to do, but they're not the same. And when we test them, we also see that. We see that, yes, they're functioning very well, but we now know that some of those people do have disease in the brain and they are heading towards dementia. And so we do not ignore these people. And in the coming years, one would hope that we will be able to test these people and tell us, so that we can know who has disease in the brain and who doesn't. Because if they do have the beginning of their Alzheimer's disease, you would hope that you would then have an intervention to stop it at just an early stage of the disease. And I think, it's really important to think of what are we able to do, right now, without having clear diagnosis, without having, in many cases, without having cures. We all know right now that dementia risk is reducible. There are many things we can do today to reduce our risk of developing dementia. We know that diabetes is a high risk of dementia, so needs to be treated. Smoking needs to be stopped. High blood pressure in midlife increases the risk of vascular dementia by 60%. This is something that we can take care of. And so it's important to not ignore our health. I always tell patients, if you don't take care of your house for 60 years, you will be living in a shack. Well, our bodies are like that too. We used to die very, very young. You know, our lifespan used to be in the 40s, and then it got to the 60s. But now it's in the 80s. You cannot afford to ignore any risk factor for that long. Education is really, really important. And it used to be thought that it was only, education when you were young, but now we know it's lifelong education. Depression, obesity, increases risk, needs to be treated. Physical activity, cognitive stimulation decreases risk. So there's lots of evidence that dementia risk is reducible. So we are not helpless and, without and hopeless that this must happen to us. In 2020, the new risk factors for dementia was put forth. And this was a revision and added 3 more risk factors. And so these are thought to be modifiable risk factors for dementia and to contribute significantly to the development of dementia. So things like what they ended up adding was head injury. So we know now that it's really important to try to avoid head injury and especially repetitive concussions. Air pollution has made it to the list. Excessive alcohol consumption. We know that things like hearing impairment can also increase our risk of dementia. So there's lots of things that we can be doing and promoting in ourselves and in our family to be able to reduce the risk. So what about, the treatment horizon? What's there? There's different types of research, okay? And I think it's important for us to consider that because, one of the only ways that we're going to be able to move forward in terms of finding treatment is to be able to enroll people in treatment trials. And I think it's important for us to understand the different forms of treatment trials. So there are some treatment trials that are only for symptomatic, okay? So that means that they will improve your symptoms of Alzheimer's disease, whether it's your memory, your depression, your agitation, something, but will not change the course of the disease. I like to think of those like your flu or cold medicines, right? It makes you feel better, and that's good, and that's important, but your cold's gonna last the same amount of time, which is very different from what we call disease modifying, okay? These are the ones that we have much hope for. These are treatments that will actually prevent, slow down, or stop the progression of the disease, right? So this is what you think of, this is your hope also in things like cancer, right? We want things that will stop the cancer, remove it. Well, this is what we call disease modifying. Then there's this concept of pharmacological versus non-pharmacological. Pharmacological usually relates to drugs, okay? So this is usually from the pharmaceutical companies, but there is also a lot of non-pharmacological treatments. So these are related to lifestyle, nutrition, environment. Then there is patient-related research. So this is with the patient themselves. But dementia, unlike many other illnesses, there's a lot of caregiver research because it is very important to consider that the caregivers with our patients are part of the treatment armamentarium that we have and makes a huge difference to a patient's life. And then, of course, policy research. Anytime you have a disease that affects so many people in the world, when you think about it, the latest numbers were over 50 million people in the world have a dementia. You need research in policy. What is the best way of dealing with these problems? So we're going to focus more on Alzheimer's disease because I think that's where the treatment trials are ahead. And Alzheimer's disease, so have 2 things that we could attack. One is the amyloid plaque. So this is a protein building up in the brain called amyloid, and it causes damage to the brain, and you end up with the symptoms that you see in Alzheimer's. The other one is tau. They're called tau neurofibrillary tangles. They're a little tangle here, and this also damages the brain. This is actually even more damaging to the brain and causes the shrinkage of the brain because it actually kills the cells of our brain. And so the thing is that Alzheimer's disease, you actually have 2 bad proteins that you could go after. And in the recent trials, okay, this is just an overview of what kind of trials are coming out. You can see that 43% are non-pharmacological interventions, okay, and 38% are for early stage. So this is, when I was telling you that patients have to be treated when they're at the early stage of the disease, because that's when you want to stop the disease when it's still, you still got a lot of good brain function. And then you have a smaller amount aimed at the psychiatric symptoms of dementia, and then for very late stage. And this is just to tell you that when we think of these bad proteins building up in the brain, there's lots of processes that happen to do that. And so there's many different areas that we could try to intervene. It's not that easy, otherwise we'd already have done it. But there are many targets that we could go after. And many of the trials that you hear about, that's what they're doing, is going after different targets, trying to stop the accumulation of these bad proteins. And so right now, the way we think of trials, okay, and so sometimes you will see this, is that you have primary prevention trial, which is basically you have no pathology, right? You just want to keep the person is normal, and you want to keep them normal. You don't ever want to see any pathology. So this is at the very, very, very early stage. And you can think of this could be for everybody, right? Then it's when you start to accumulate some pathology. So you're starting to accumulate these bad proteins, but you are completely normal. You have no problems at all, but you are starting to accumulate this. And so if we could detect it, the hope would be that we target these processes, and that you never ever progress into these other stages. And then of course, when you're already showing signs of disease, what can you do? And this would be treatments to slow the progression, to remove, it's hard to think of reversing things like, giving people back brain cells. That I don't think we're near to that. But you could think of preserving all those brain cells that have a little bit of injury, but are still good, and preventing them from dying. So this is just to show you, this was from 2018. This was all the different trials in the different phases that were targeting different aspects of Alzheimer's disease alone. So you can see it's a very, very active field. People realize this is although we often hear about all the failed trials, many of them have taught us, about intervention. They've taught us what things work, don't work, what stage to go after. So people haven't given up hope. There's a lot of work in this area. Currently, I just looked in Ontario, there were 41 studies that were actively recruiting for Alzheimer's disease. And when I looked, this was in 2018, you can see that a lot of effort is moved towards disease-modifying therapies. These are the ones where I told you we're really trying to change the course of the illness, and much less in terms of symptomatic treatments. This was in 4%, and then obviously the psychiatric symptoms of Alzheimer's, which are a big problem. So I'm going to talk a little bit about the non-pharmacological therapies that I think, I'm hoping received enough attention, but I'm still surprised sometimes to see that people aren't aware of them. There is so much evidence for lifestyle modification making, really changing the course of this illness. This was a large study in 3,000 twins that were followed for 25 years. And the big difference between those who developed dementia and those who didn't was the amount of vigorous physical activity. So I always tell people, it's, vigorous is usually more than walking. You want to get your heart rate up, unless you're a brisk walker, or, I tell people walk uphill, but do things that get your heart rate up. Because this study really, and this and many other studies have shown that it's the vigorous activity that helps us. Even in normal elderly people, so people who have not exercised their whole lives, but they take up exercise late in life, they have shown that there's a very significant effect on cognition, on functional ability, on mental health, and it could, improve your cognitive speed, delay your delayed memory function. So that's, the recall, could help your attention, and that it was actually associated with the delay of developing dementia from 3 to 6 years. What about if you already have the disease? I think people, have always been worried, well, if I've already started developing signs of this disease, or I've already been diagnosed with this disease, what does that mean? Well, there's lots of evidence and growing evidence that even if you've already started this illness, okay, that there is room for you to improve the outcome. So in mild cognitive impairment, physical activity was associated with reduced rate of cognitive decline and improved behavioral measures, could help in the neuropsychiatric symptoms. And the kinds of activities we wanted were higher intensity and aerobic type. So that's what I was talking about, is that those kinds of exercises that make you sweat, okay? It's very important to do that, to get your heart rate up. What about the cognitive reserve? This again is a really interesting and recent concept. So I think, for a long time, people thought if you had attained higher education, that this was protective. And there's a lot of evidence for that. But I think what we realized in the last few years is it's not only higher education, it's also, lifelong learning. So people who had more complex jobs, who remained socially active, these people were more resilient to the ravages of Alzheimer's disease. So even if you had Alzheimer's disease, it progressed more slowly. And that's very important, keeping people out of long-term care facilities, allowing people to stay home longer. So anything we can do to allow people to retain their function, I think we should be, invested in. And the thing is that, you do have to put in the time to learn. You have to put in the time to do the physical activity, but those don't actually have that many side effects, which I think is, very important when you think of, some drugs that were given and the amount of side effects that they have. And so, in this study, they actually had shown that even if you have Alzheimer's pathology in the brain, if you had cognitive reserve, you actually function much better. So this was significantly better than people who didn't have it. So it's something that's very important. And I think recently we've shown that in women, where I think there's been a lot of data to show that women seem to be at higher risk of Alzheimer's disease, and there's more women living with Alzheimer's, and some of this is because women have longer lifespan. But what they're actually showing is that this also is related to the fact that women, unfortunately, have not had the same access to education and to challenging jobs. And so that this also could have had a significant contribution to the amount of Alzheimer's disease in women. As well, they are not as physically active as men. And so this too, so when you think of, the number 1 and 2 modifying factors in dementia are, physical activity and cognitive reserve, and women have, for the large part, not had equal access to that as men. And could this be, why women seem to be at higher risk? So what about ongoing disease modifying research? There's lots of it. Like I showed you that grid. There's hundreds of studies throughout the world, and they're either attacking the plaques, they're blocking production of amyloid, they're attacking tau, they're blocking the formation of those tangles, they're trying to prevent the destruction of the connections between nerve cells, reducing inflammation. This is a very active area of research. There's research on insulin resistance, heart-brain connection. So, I think the cardiac people have been ahead of the game for a long time because they've had a lot more invested dollars in their research. And so we know that there's lots of things that you can do to help the heart, but we also know that many of those things will also help the brain. So there's 2 drugs that are now actually before the FDA, which is the equivalent of a Health Canada, but it's the one of the United States, and they're looking for approval for Alzheimer's drugs. So we'll find out in the next few months, and if they pass, then there may be 2 drugs that are actually considered to be disease modifying for Alzheimer's disease. And then of course it will, be important to try to figure out who these drugs should be targeted for. And so we'll have to make sure that we have good tests in place to be able to pick up Alzheimer's disease, to be able to give the drug to the right person. And so, I talked a little bit about this, that there's, lots of pharmaceutical interventions. There's what we call nutraceuticals. And pharmaceutical interventions are really drugs, right? Which is different from the nutraceuticals. And oftentimes I have people coming to me and they have a lot of these supplements that they're taking. They've heard all about, omega-3 or vitamin D or choline, or, every few months it's a different one. And I think it's really important to understand that, there are people who actually do studies with their drug, with the product, but many times these products don't end up in a study. And so because they're declared nutraceuticals and they're not governed by the same laws as the pharmaceutical industry, they could pretty much say anything about their supplement and not really have to have any evidence to prove it. And you as a consumer can choose to buy it or not. But I think it's really important to realize that there's no reason these vitamins, these minerals, all these things do not undergo the same types of trials as the pharmaceutical products. And you would want that, because what you want at the end of the day is to take something that is going to be of use to you. You do not want to be ingesting anything that has no proof that it's going to make a difference to your health, especially for your brain health. But like I said, there's many different products out there that can be trialed. There's some that are medical foods now. There's also these neurophysiological interventions. So there's, you can stimulate the brain from the outside. You can even do deep brain stimulation. You can do neurofeedback, laser light therapy. There's all these different types of interventions being tried. And then, of course, the ones I've spoken about, the physical health interventions, which include like aerobic exercise, as well as, Mediterranean diet or medical management of disease. There's cognitive interventions. There's lots of evidence for doing different activities in the brain with the brain, so that you can retain cognition. So, people doing speech therapy to retain language function. Engaging in stimulating classes, or there's lots of things, lots of different types of interventions that people can go through. And then behavioral interventions. So obviously occupational therapy to do for home assessment, and what kinds of interventions can help keep a home safe. What types of low stress calming environments. There's sleep, meal schedules. There's all kinds of things that we can do studies on to see what is the best method for keeping people as well and for as long as possible. And obviously future planning interventions. So, what kind of caregiving counseling, when to do advanced care planning, legal services, lots of different financial advising for estate planning. So this is just to tell you that the number of different research protocols that can be put forth to try to advance all aspects of care in dementia are very vast. And I think, it's just important to realize that they're out there, and that, you could participate if this is something that, is of interest to you. These are 3 websites that are really good for learning about what's out there. So the first one is the Alzheimer's Society of Canada actually has a portal to different research projects across the country. Some are maybe in your local area, some not. Then there's an international one called clinicaltrials.gov, and that lists all the trials in the world and where they're being done. And, you know, if you found something that you liked, you could try to, they usually have a contact person and you can find out if there's something local. And then there's the Toronto Dementia Network, which is associated with the Alzheimer's Society of Toronto, which will also list those more local studies that you can intervene with. And many of them are not pharmaceutical studies. Many of them are other types of interventions that we also think, you know, and are hopeful can make a difference in people's lives. This is just to kind of tell you how much funding has been, you know, invested in Alzheimer's disease versus other diseases like cancer and heart disease. And so, you know, when people think of why have we not made the strides that others have made, heart disease has come a long way, and cancer, as we all know, has done remarkably well. I think it's important to think about this. These are old figures and they're American figures, but our Canadian figures are unfortunately very similar, except for the dollar amounts are lower. Cancer far outreaches any other disease, and the heart also does, you know, not so bad. Alzheimer's disease is the one in blue, the dark blue here. And so, you know, not really, this was the actual, not really doing as well as we would like, especially given that Alzheimer's disease is now the most feared disease by the WHO assessment. I think, you know, it behooves us to advocate for more research funding for Alzheimer's disease and all other dementias and all other causes of dementia. And so to summarize, I think, you know, an accurate diagnosis is really important to be able to, you know, get to a cure. We need the right people and the right trials, and it really is the first step to treatment. There's lots of new discoveries, and these new understandings are really bringing new treatment options. And I think it's really important to consider that, you know, what we know today gets us this far, but, you know, sometimes even if it's not a study in an intervention, it's still helping us move the pendulum forward to be able to get to that. Disease-modifying treatments are an active area of research, and I think, you know, for the first time, we are really envisioning some disease-modifying therapies in Alzheimer's disease. Will they be the end all? Probably not. You know, I think we can all appreciate that although there's been great strides made in cancer, all of us know people who have died of cancer, and so I think, you know, this is an active area. But I think that we are no longer hopeless about, you know, discovering a disease-modifying treatment. I think we think that's very close at hand. And there's a lot of evidence for lifestyle modifications. And I think we can all participate in that. Doesn't matter our age, doesn't matter where we are in our, you know, in our journey towards dementia, maybe. There's a lot of evidence that lifestyle modifications can change that course of disease. And that's it. And I thank you all for listening and open to any questions. Maybe I'll stop sharing my screen. Hello.
Thank you, Dr. Tartaglia, for sharing all that information. I feel hopeful that we will find a lot of answers to what we're looking for. So in terms of questions, you can certainly use the chat box. You can also, at this time, unmute yourself and ask your questions if you have any.
I have a question for Dr. Tartaglia. My husband has a pacemaker. Does that make him ineligible for any MRI studies of the brain?
So there are two answers to that. So the more recent pacemakers are MRI compatible. What we usually do is a cardiologist has to be at hand to be able to reprogram it afterwards. It depends on how vulnerable to heart stopping your husband is, because you know, an MRI can be 20 to 30 minutes, but that's enough to kill you, right? If so, it depends. Some people just have them there in case it doesn't happen that often. Then I think that's okay. It also depends on when it was, you know, implanted, because some of them can go into a magnet. They have no problem, but they'll get deprogrammed, right? Because of all the interference. The problem is some of them, they can't even go into a magnet because they could burn the person. So there's a lot of things to figure out, but it's not an exclusion. It's not a complete exclusion anymore.
Okay, he had it in January this year. He had it installed.
Yeah.
So
if he really needed one, it's just that we, you know, it's one of those things you want to weigh the benefits, you know, and cost. Like, does he really need to get the MRI? Will it change, you know, the course? If it's just looking for patterns of shrinkage of the brain, we could do that with a CT scan. If you're looking for a specific type of pathology, then, you know, an MRI is better. I think it's one of those things where there's no clear-cut answer. It's on an individual basis we make that decision.
thank you very much.
I saw one question on, would you be able, oh, I don't know if there's something above that. Would you be able to enlighten us on the role of glial cells in Alzheimer's disease or gliocentric research? Yeah, so that's a great question. And actually, there is a lot of research on what we call microglia or astrocytes. I think people have realized that it's not all about the neuron, that, you know, these cells that are deemed supportive cells may also be playing a role. And so actually we are, in my lab, we look at, you know, inflammation, which is basically a reflection of microglia and how it affects the neurons. So I think we're opening up our minds to this not being just a neuron-based disease. So great question.
So we have another question here, Dr. Tartaglia. It's what is the process to determining possible cognitive impairment? Do we start with our general practitioner or another professional?
So I think, well, that's a great question. And I think, you know, the first thing to do is to bring it to the attention of your family doctor. Most people have a really good and long-standing relationship with their family doctor, so they can say, you know, things have changed for me, or I noticed this, and it could be not in yourself, it could be in somebody else. And then usually the family doctor would do some kind of screen, you know, because you want to make sure it's not just due to your thyroid problem or B12. You know, there's certain things that we have to screen for and make sure everything's all right. Because like I said, many different things can affect your cognitive function. So once your family doctor does that, they do a screen like that MoCA or the MMSE that I showed you. So asking a few questions, and then they see how you score. And then from there, either the family doctor, you know, there are primary memory care clinics in the province. There are family doctors who actually specialize in memory and diseases and cognitive diseases and dementias. And so you might be referred to one of them. Those people, if they need some help in the diagnosis, they actually refer to us, even through e-consult. So sometimes we don't have to see the person, but just with the story and, you know, the different testing, we can figure out what the person has. So I would say the first person would be your family doctor.
Dr. Tartaglia, there's another question here. It says, can Alzheimer's be acquired by family inheritance? And is there new evidence about this?
Yeah, so that's a great question. So there are a few cases in Alzheimer's disease that are what we call autosomal dominant or Mendelian genetics. It's a type of genetics where if your parents have it, there's a 50% chance that you have it. That is actually very, very, very rare in Alzheimer's disease. It's a very small percentage of the population that has what we call these familial Alzheimer's disease. These people, you can pick out the families. It's generation upon generation with all these people who are in their 30s and 40s and 50s who have Alzheimer's disease. Most of them are dead at very young ages. The big cohorts right now, there's like a big one in Colombia, a few in the United States, a few in Europe. There's very few of these people, but it is, you know, it is a group. Then there's this other concept of genetics where we think of these genes that when they all come together, they play a role and put you at higher risk of getting Alzheimer's disease than somebody else. And you can think of it in this way. You know, when you think of cancer, many cancers, there's no rhyme or reason why the person got it, right? There's nothing they did in their life. There's, you know, they don't even have a family history of it, but there's something about them that made them prone to getting the cancer. Well, a lot of times that is some genetic difference, not a big genetic problem, but a genetic difference that predisposed them. And we think that that's what's going to show up in Alzheimer's disease, that multiple little genes are going to come together and they're going to put you at higher risk of getting Alzheimer's disease. And then there could be some other factors, right? Like maybe your lifestyle wasn't great. Maybe you were sedentary. Maybe you smoked. Maybe you hit your head a lot. So those things would play together and your risk would go up. So do we think there's a genetic component? Yes, but it's not the same type of genetic disease where you think, oh, I got this gene, I get this disease. No, that's very rare in Alzheimer's disease. Hope that answers it.
Okay, there's lots of questions coming through. Someone else wrote, my dad is recently diagnosed with Alzheimer's. He and my mother are debating whether he should take Donepezil, which was mentioned by his practitioner, who said its impact was modest at best. Can you speak to that?
Yeah, so I think that the thing about Donepezil, it's a family of those kinds of symptoms, of those kinds of illnesses, of the treatments that are really for symptoms. So the evidence that Donepezil is disease modifying is very, very slim. Not none, but slim. So most of us don't think it's very highly disease modifying. But I'll tell you something, that for the patients that it works in, their families tell you that the person basically has gained back the past year. Because what Donepezil does is what we call an acetylcholinesterase inhibitor. So let me just explain what that is. Basically, your brain has cells that make this acetylcholine. And this drug stops its breakdown. Doesn't make it make any more. It just prevents the breakdown, okay? Not indefinitely, but it allows the acetylcholine to hang out a little bit longer. What does acetylcholine do? It helps you register information. And so in doing that, it allows you to take in more information. And if you're always going to remember 50% of what you see or register, well, you could say just the sheer math of it is going to show up as you remembering more. So a lot of patients try it, and I honestly have to tell you that I, make sure I inform all my patients that I think have Alzheimer's disease to try it. So first thing, make the diagnosis. So your dad, I'm assuming, was told he has Alzheimer's, and then into treatment options today, which are symptomatic, Donepezil is first line. So I think unless there's a contraindication, there's no bad reason to try it. But sometimes patients will say, well, I don't notice. Their family will say they don't notice, and I don't really bother. I think there's a lot of treatments like that. Sometimes people don't notice the big change, and when we take the person off of it, they do see that it was doing something. Yeah, it's hard to know. You have to remember Alzheimer's is a progressive disease. So sometimes even people who can stay the same, that means the drug is working because it's keeping you at a, kind of status quo instead of the trend is for not the trend, the progression is for you to be losing memory over time. So it's something to really consider.
Okay, so on that line of progression, another question is MCI reversible or is it progressive?
So that's a great question. So MCI is basically just mild cognitive impairment. And the issue is the diagnosis of MCI. So MCI describes a person who basically could have non-degenerative disease. So let's say you have your thyroid dysfunction is causing you to have mild cognitive impairment. Well, when we fix that, we could, basically reverse your MCI, right? If it's due to some inflammation. So then in those cases it is. If it's a degenerative process, so let's say your MCI is due to Alzheimer's disease, it is progressive. And those people every year, 15 to 20% will convert into Alzheimer's disease dementia. So it really depends on what the cause is of the MCI, but the neurodegenerative one, like let's say, you have frontotemporal dementia as your frontotemporal degeneration is the cause of your MCI, that will progress into dementia. It's not reversible at this time.
Okay, thank you. I'm going to merge a couple of these questions because they're on lifestyle. And so how much does lifestyle contribute to the development of AD or vascular dementia? And is it only to those types of dementias or to all types of dementias?
Great question. So because those are the most common types of dementias, I think they have the most evidence for them, but there's actually evidence for cognitive reserve even in frontotemporal dementia. So right now, we think that lifestyle modification can help all types of dementia. Parkinson's disease dementia is actually also kind of joined the ranks of diseases that have, really engaged and embraced lifestyle modifications. And there too, people are noticing that they can have, that it can make significant difference, a significant effect on the progression of the disease.
Okay, what is the latest research showing intravenous treatment that destroys amyloid plaque? I heard that another treatment was being looked at by the FDA. What do you think about this type of drug therapy?
Yeah, so those are the two drugs that I said were before the FDA. They are anti-amyloid treatments. So they're monoclonal antibodies. So basically they're giving you a drug that's going to attack the amyloid and try to get it out of the brain. I think that's where the optimism has lain so far. This is, not to ignore all the many failed trials that have occurred. But I think we've gotten better at doing trials. People have become more savvy. They've become better at picking the patients who should be given these treatments. It used to be that they would give it to people who didn't necessarily have Alzheimer's. Secondly, there were people who didn't, they were at late stages of the disease. It's very difficult to see change. When you think of testing a drug, the way you test a drug is you test somebody on something, like let's say you did a mocha, and then you give them the drug, and 3 years later, you test the mocha again. And then you say, okay, well, did it change? Did it, get better? Did it get worse? How much worse? What about if you didn't give the drug? How much worse would it have gotten? So, these are nuances here. And so it's very important to create good trials to be able to pick up if a drug really works or doesn't work. So I think right now we're optimistic that one of these drugs will go forward. But I think there's also drugs aimed at tau, and that is also a very important protein in the brain. And so that could easily be even more important than amyloid. We just don't know right now, but they're active areas.
Are there any studies about the effects of long-term use of psychotropic therapies on dementia or Alzheimer's?
I guess it depends on what they mean by psychotropic, like neuroleptics. Yeah, maybe they could clarify which psychotropics because there's lots of different ones, and some have a bad effect and are associated with increased risk of dementia, and others not. So Is there something that they were thinking about in particular?
So wrote in to treat mental health.
Yeah, so most of them are not associated with dementia. The only ones that keep getting, so things like antidepressants, medications to treat many of the mood disorders are not associated with dementia. And actually we think treating depression is a good thing because it has been associated with dementia. The ones that always come up as bad, or there's an association between the benzodiazepines. So these are clonazepam, Ativan, all the PAMs, let's say. Those ones, they keep getting associated with dementia. And so they're put forth as a possible risk factor, but it's very difficult because it becomes a chicken or egg. Is it that you had a problem, you went on this drug, but you already had this dementia starting? I told you, we're building up these diseases way before you actually pick them up. So maybe your anxiety that you developed late in life or was due to that. So it's hard to tell, but definitely, at least, whenever possible, I try to get people off of PAMs because of that association. I'm not saying it's, it's not causal, but that association always worries me. The rest of them, not at all. I think some of those are actually good for your brain.
So we'll continue along with another question regarding medication, and this goes back to the use of Donepezil. So how long does Donepezil typically work for, and do you recommend stopping it once benefits are no longer apparent?
Yeah, and that's a hard one. So I think, once patients get on it and they don't have any side effects and they're tolerating it, I don't actually pull people off of it. But if the patient starts to develop some side effects, or they have trouble swallowing, or in some cases the patient is resisting, or they don't want to take it, then I don't have any hesitation in stopping it. It's like I said, I think the problem is that we don't have very good evidence that it actually modifies disease progression. I'm not saying it doesn't at all, but the evidence for that is not really there. So it's very difficult for us to say, oh, you must, you really should stay on it because this will change the progression of your illness. I don't think we have that data. So as soon as somebody tells me, I don't want to take this anymore, or my family member's resisting the medication, I'll be like, okay, get rid of it. And sometimes I'll tell you, families will say to me, well, I got rid of it because I didn't think it made a difference, but now I notice a lot of decline. And like I said, sometimes, these are progressive illnesses. So the fact that a medication keeps you trucking along at one stage is actually not a bad thing. And sometimes people only notice that once they stop the medication.
Okay. You mentioned that OHIP doesn't pay for the Alzheimer's test outside of research, but that one can pay to have it done. If someone is interested, how would someone arrange this?
Yeah, so in my clinic, we would do when we think somebody has Alzheimer's, because there really isn't any point in sending a person for a test that is kind of expensive. It's almost $2,000. If we don't think they have Alzheimer's, or we're not that confused about what's going on. But otherwise, we can do it because it's just a matter of doing a lumbar puncture and sending the fluids off for assessment. So in my clinic, we do it. And I'm sure there's cognitive neurology clinics across the city. It's not done everywhere, it's true. But the cognitive neurology clinics across the city usually can do a lumbar puncture if a person's willing to pay to have it sent. We used to do them before when OHIP covered it. So the same thing now.
Okay, and there's another question about medication. What about antipsychotics such as Abilify for control of agitation, anger, and mood?
Yeah, and I think, those symptoms are really actually bad for people's health. And so we need to control them. There's a lot of evidence that, so I guess I'll answer the question in two ways. If a person has long-standing, let's say, bipolar disease or one of these mental health issues, treatment is what allows people usually the best quality of life. Okay, so that has to take precedent. There is no evidence that these medications are affected with brain degeneration. We actually are accumulating evidence that untreated psychiatric disease could be associated with, degeneration. And sometimes when people have psychiatric symptoms due to their neurodegenerative diseases, that actually can put them into harm's way, and it's very important to treat. So again, everything is a cost benefit. We do try to stay away from neuroleptics as much as possible in our patients, because we know that they are, it's the side effects, like your increased risk of falling, that actually is what we worry about. Not that the drug itself is damaging the brain in any way. We, at the foremost of our treatments are to make sure that agitation and neuropsychiatric symptoms are controlled, because they actually are the biggest risk factor for institutionalization of patients.
Thank you for that. And there's one additional question. It says, other areas of research, what about other areas of research such as music therapy with 40 hertz?
Yeah, I don't know about music therapy with 40 hertz, but there's lots of evidence for music therapy. I think art therapy, music therapy, there's lots of evidence that those can be quite beneficial. And you can think of, they also help with cognitive stimulation of the brain. In some cases, they've also been shown to be good for personalized music, has been shown to be pretty good for agitation. So there's lots of evidence for music therapy. In terms of it changing the course of the disease, I think maybe less there, except if you think of, if you're doing it in a group and it's, contributing to your socialization and cognitive stimulation, I think there's lots of evidence that that's actually good for your brain.
Thank you. There's no other questions right now in the chat. I'm not sure if anyone has any additional questions.
Yes, I do. Hi. Maria, I have a question.
Yes, go ahead, Anthea.
Yeah. Dr. Tartaglia, have you heard of the clotho gene or clotho enzyme?
How do you spell it?
It's KLOTHO.
Oh, clotho, yes.
Clotho. How important is that in maintaining cognitive reserve or cognitive function?
It's one of the, I think, the new genes that was found. I can't remember. There's the gene that encodes it. I think there's like different forms, and it looks like one of them might be more, maybe change the amount. And so it's one of the areas that's been looked at. And then, I think there's a study in this clotho enzyme and in various diseases, not just in dementia.
Okay.
And I think, we have to keep our mind open, because we don't have a cure, right? So we don't know where to look, where to not look. I think all we want is to make sure that that there's rigor in the assessment. So I think there's been a few, I think that's the one where there's been a few of the large genetic studies that have found that different variations of clotho are associated, like maybe a risk. And so the other aspect is then to look at, changing the levels might help something or hurt something, so I think it's an active area right now and a newer area.
Thank you.
There's one additional question that just came through the chat. I think you touched on this before. How are dementias diagnosed now? You mentioned earlier that since 2013, a biomarker needs to be present, but in my understanding, these procedures are not covered and are only used for research.
Yeah, so it's a good question, and that's how we that's how we can do the diagnosis. So patients who enroll in research, sometimes we can get them the tests. And so there's like PET scan research, there's lumbar puncture research, and then patients can pay to have this test covered well, they pay themselves. The company that does it, that used to do it when it was covered by OHIP, still does it. The problem is that now we can't get coverage for it. So I think right now what we do is I still do lumbar punctures for patients who want to, where I really suspect there's Alzheimer's, or actually I'm very uncertain because there are other diseases that can look like Alzheimer's but not be. And so we can do lumbar punctures and we send the fluid away. But unfortunately, it's, it's quite an expensive test. It can be almost $2,000. It's in American dollars, so it depends on the currency, but it's very expensive right now. So right now, the diagnosis is made with your history, your testing, looking at your brain, and sometimes we tell people it's like we have to follow you over time. Alzheimer's disease has a progression that is different than frontotemporal lobar degeneration, which is different from other diseases.
Is there any specific research geared towards vascular dementia?
Yes, there is research towards that, because vascular dementia is really a preventable dementia for the most part, right? Because there's many lifestyle modifications you can do that could, improve your vascular health. And that means things like control of blood pressure, control of your cholesterol, making sure your sugars are okay, making sure if you have sleep apnea, that it's treated, making sure that you're not sedentary, making sure that you're, stimulating your brain. There's lots of things that you can do that help blood vessels in the brain, and as a consequence, would stop or prevent vascular disease dementia.
Someone had a question about the lumbar puncture specifically, and what does it exactly show?
So a lumbar puncture is a procedure that we do where we put a needle into the base of your back and we can get to the spinal fluid. The spinal fluid is made by the brain, but luckily it's made by the brain, is around the brain, but also all around the spinal cord and below the spinal cord. So we can do a lumbar puncture where we put a needle in. It's the same kind of procedure women get as epidurals, or even men can get epidurals, except that we don't inject anything. We just take the fluid out. And that fluid, we measure the tau and the amyloid. And by measuring those proteins, we can say yes or no, you have Alzheimer's disease. There's a certain pattern that we look for. I think there was a question on how do we prevent destruction of the synapse? So that's a good question. That's an active area of research, because synapse is the connections we have in the brain. And so right now we do have evidence that exercise, like physical activity, can help prevent destruction of the synapse. There's a lot of research in inflammation and anti-inflammation because that seems to also be affecting the synapse. So, we don't have anything right now, but that's where we think the problem really is, right? Like these bad proteins are building up in your brain, but actually what they're destroying is the synapse, which is basically another word for saying connection between two cells. And that connection is what allows us, the communication, allows you to learn new things. And that, is what ends up dying in cases like of Alzheimer's disease. Hopefully that answers that. I don't know if there's any other questions, or I don't see anything in the chat.
One just came through.
Oh, okay.
Is sugar a cause of inflammation in the brain?
Yeah. Yeah, I think there's definitely some accumulating evidence that, because diabetes. So when you think of diabetes, it is associated with inflammation in the brain. And so, that doesn't mean sugar is going to cause inflammation, but we do know that diabetes, which is a problem with the metabolism of sugar, is associated with inflammation. So we think that excess sugar is bad for you. Not a moderate, not the normal amounts we get in our daily lives. It's the extra sugars that are bad for us. I mean, when you think of, what has evidence, it's, the Mediterranean diet, and it's not a diet that's, heavy in sugar, right? So I think it's just about having balance in your diet.
There doesn't appear to be any other questions now, but there's a lot of thank yous. So thank you for your great presentation. People are writing that in the chat. Thank you for patiently answering our questions, someone wrote. And so there's lots of thank yous for your presentation.
Thank you all for coming and for staying, and and for your interest in this. I think it's a really important area, and I think we should all be thinking about it. Doesn't matter our age. Yeah.
So thank you again so much, Dr. Tartaglia. For those who are here, just some things to be mindful. I have posted the evaluation link. I'm actually just going to repost it now. This is going to be really helpful for us in terms of gathering the feedback, but also informing future sessions. So if there are particular topics around dementia that you do want to explore more, please do note them down, and we'll try to organize speakers for those. And so if Dr. Tartaglia is free, we may have another presentation there. And also the slides will be posted on the UHN clinic website, and we'll also be sharing the video. So I would say give us about a few days of lead time to get that together and get that posted, but they will be available.